Good morning, everyone. My name is Leslie Parks, and I'm the Head of Marketing at Integra Canada. We would like to welcome you today to our educational webinar sponsored by Integra and facilitated by Wounds Canada. Today, we are excited to present Evolving the Standard of Advanced Wound Care with MediHoney. It is my pleasure to introduce our guest speaker, Dr. Alan Rogers, who is an assistant professor, burn surgeon, and plastic and reconstructive surgeon at the Ross Tilley Burn Center at Sunnybrook Hospital. Dr. Rogers' main clinical interests relate to comprehensive burn care, complex wound care, and reconstructive surgery, especially in trauma, pressure sores, and burns. Before we get started, just want to cover a couple of housekeeping items. Please note that everyone's been placed on mute during the presentation, and we'll open up for question and answer at the end. Please submit your questions through the chat box, and feel free to submit questions throughout the presentation, and we'll address them at the end. So with that, I'd like to turn the program over to Dr. Rogers.
Good morning, everyone. Thanks very much, Leslie, for that introduction, and I really appreciate the opportunity to share some thoughts, some experience with MediHoney. As mentioned, I'm about 3/4 of my work is the management of acute and reconstructive burn surgery at Canada's largest burn centre. I get involved as much as I can in the management of complex wounds and chronic and acute wounds in our centre. Given that we're the largest trauma centre in Canada, we also see some severely injured patients, and we see some of the worst in terms of complex wounds. Very fortunate to work very closely with some exceptional nurses and other members of the multidisciplinary team. And we try to apply some of the principles that we use in burns in the more complex wound scenario, because we find that we get optimal results in that way. And I think there's a lot of scope for that across the whole spectrum of wound care, particularly that requiring management in a hospital setting. So the objectives and outline here is to review the history and science of MediHoney, consider its impact on wound healing from a research point of view and from a personal perspective. Also see how it is possible to integrate MediHoney into a treatment algorithm. In burns, which is, as I mentioned, a lot of my work, we use a lot of antiseptic dressings. And MediHoney has become one of those, but traditionally it was always seen as a sort of second line option. And I'd encourage those out there, both in community and in the hospital setting, to consider it as a first line option. And I'll hopefully be able to encourage you to do that over the course of this talk. Many of us view honey as almost as a natural product, and therefore either are swayed to use it because of that, or are skeptical of it because of that. So I'm trying to find a middle ground here. I personally don't like to eat honey, so I see it as a dressing product. Similar to the fact I don't really use vinegar on my French fries. I use it in the management of difficult Pseudomonas infections. So I'd like you to consider it in the same way. Honey's actually been around longer than virtually any of the other antiseptics in the management of wounds. And in fact, there's reference to it in the tomb of King Tutankhamun, and in several of the papyruses from Egypt almost 4,000 years ago. It's also referred to by Aristotle and Hippocrates in ancient China and the Middle East, and some of the sort of forefathers of surgery and wound care in the Middle East and India. My great-grandfather was involved in the First World War for Canada, and actually fortunately lost his leg fighting at Passchendaele, where Canada really made a big difference in the outcome of the war. And he told my grandmother, who then informed me, that they'd actually used honey that they'd learned from the Russians to apply to wounds. At that point, as you know, there were no antibiotics, and so a wound of the type that he had from a gunshot quite frequently resulted in wet gangrene and death. And in fact, he mentioned that it actually rapidly helped and got him through back to behind the front line, where he was able to have his amputation and lived another 75 years after that. It is referenced in World War I, but it lost favor a little bit after World War I with the advent of antibiotics, and people started to rely too much on antibiotics. And as you know, we now have a major problem because of that reliance on systemic antibiotics. We have a major resistance problem. And that's why I think honey has made a resurgence, led by MediHoney and Integra, Lifesciences, with recognizing that we need better and topical antiseptics rather than systemic ones. And MediHoney's really advanced the user friendliness of this product in incorporating into the whole spectrum of wound care products, from hydrogels all the way through to hydrocolloids and talgras. So what is honey? Honey is, as you know, a viscous hypersaturated sugar solution. The bee drinks the honey from the plant, and enzymes break it down in their honey stomach and breaks it down into its constituent fructose and glucose. And then they spit it out into cells of the honeycomb that you see there, and then seal it with wax. And then they flap their wings very fast to allow it to mature and ripen. What's in it? It's mainly sugar and water, but it has a number of other interesting constituents, including proteins, vitamin B complex, and a range of antioxidants, including flavonoids, ascorbic acid, catalase, and selenium, and has a number of organic acids as well, which cause it to be slightly acidic, which accounts partly for its wound healing capacity. Manuka honey, specifically the type found in medical honeys, is derived from a region in New Zealand principally, and also some in Australia. And it's from the Leptospermum species from New Zealand, which flowers only a few weeks per year, and it's big business now, and they've really become very efficient. And as I mentioned, Manuka is quite unique. It's got a unique scent. Its thixotropic characteristic makes it useful in wounds, and those of us who've used it recognize how it does gel when standing, but it also flows when warmed and on the body. As you probably know, table honey is easily contaminated, and so it's important that MediHoney is sterilized to reduce the chance of any contamination, so that it can be on the shelf. It's sterilized by gamma irradiation, and this does not destroy any of the positive properties, but in fact makes it usable as a wound care product. It's sterile. It can be traced. It's in terms of where it comes from, should there be any trouble, and it's also farmed in pesticide, antibiotic, and chemical-free farms. So Integra, the parent company of Lifesciences, have really, as I mentioned, transformed MediHoney's products into something that we can use, as I mentioned, across the full spectrum of the wound care sort of continuum, because of the range of products that they've used. And I think with an understanding, like with any dressing, an understanding of the products, we can make use of all the positive properties. Integra, as you know, also produces probably the market leader in terms of skin substitutes, which is Integra. It's a dermal substitute. So they have a phenomenal reputation, and MediHoney is just one of their ranges of excellent products. There are a number of therapeutic advantages that have been looked at experimentally in vivo and in vitro. It has broad spectrum antimicrobial effects, which I'll touch on. It also encourages moist wound healing. It helps to manage edema and inflammation, which I'll also touch on. Has analgesic properties, and because of the moist wound healing and other characteristics, facilitates autolytic debridement as well. One of the important features also is that it reduces odor, and particularly in the palliative care setting and the so-called unhealable wound setting, where the patient's not well for definitive closure, it has a phenomenal effect here. In terms of its antibacterial biomechanisms, the water content is relatively low and the sugar content high. And what that does is it does draw out the edema from the base of the wound. And its acidic properties also assists with wound healing, because most chronic wounds are actually in an alkaline environment. We use hydrogen peroxide in wound care to help us with hemostasis. It breaks down clot initially so that we can visualize the bleeding points when we're obtaining hemostasis. And we know that that clot is a favored environment for bacteria. And so hydrogen peroxide also activates neutrophils and facilitates the normal process of dealing with bacteria. Flavonoids present in honey also inhibit phagocytosis and quench free radicals and superoxides in the wound. It also has a number of antimicrobial peptides which are being studied. B defensin 1 is one of them, and UMF, which is a rating of the methyl glyoxyl content, is a measure of its antimicrobial potency, the unique Manuka factor. And evidence has shown that factor over 10 facilitates effective management of bacteria. In chronic and wound care, and even in acute wound care, we know that biofilm-related wound infection is a major problem. Simple wound care, the traditional wound care, does not deal with biofilms, and we know that it's like bacteria putting up a shield. They communicate with one another, and they form a barrier to most of what we can do to address them. And in fact, MediHoney has shown that it can actually rapidly reduce the presence of biofilm-related infections, including that formed by MRSA, via a number of mechanisms. It also decreases the expression of genes that are associated with the virulence of this of the bacteria MRSA. One of the big problems we have both in burn care and in chronic wound care is Pseudomonas infection. Wherever there's excessive moisture, which we know a degree of moisture is a good thing, but excessive moisture potentially favors the environment necessary for the development of Pseudomonas infection. And we know that its desiccating effect is important in managing Pseudomonas associated biofilm as well. MediHoney is an effective autolytic debriding agent in comparison with other modalities in common use. As mentioned previously, there's evidence now to show that it actually quenches, soaks up harmful inflammatory free radicals. As I did a PubMed search a few weeks ago, just in preparation of this talk, and what you can see there, as I mentioned, there's this massive resurgence in interest in MediHoney in the 90s, and it corresponds with the development of resistance due to the unnecessary use of systemic antibiotics. And in fact, more and more, particularly for MediHoney, but for honey in general, there is increasingly robust data demonstrating its efficacy. And we'll probably see that the quality of evidence increasing. As you know, the quality of evidence in general in wound care is fairly poor. There are relatively a few randomized controlled trials, but in fact there are a number of randomized controlled trials now looking at MediHoney, and as I mentioned, should now be regarded as a first-line agent in our wound care armamentarium. One of these, one systematic review that I looked at was in the burn care literature, which actually looked at MediHoney and honey in general across the full spectrum of wound care, and burns showed in statistically significant improvement in its antibacterial effect by biopsy, as well as its healing effect compared to the standard of care. In other areas, there are increasing numbers of papers showing its benefit, and but there are a number of anecdotal trials and case series showing some benefit, and hopefully in the future we will we will see more and more of that coming through in the literature. There are now 9 RCTs comparing honey with one of the standards of care, which is silver, one of the silver dressings, and as mentioned, favored honey in terms of healing time and antimicrobial effect. Then moving on to another study which looked at an area that I think is one of the more challenging areas in chronic and even acute wound care, is management of diabetic foot ulcers. And in these patients, getting wound healing is a multi-pronged approach, and I think one of them should be the topical agent, and that is chosen. And there are now 6 studies in this meta-analysis which showed shorter wound healing times, as well as bacterial clearance noted with the use of honey rather than the controls. Now, what is the control? And it varies in terms of ranging from alternative antiseptics all the way through to simple saline wet to dry approaches. There is a Cochrane review looking at generally antibiotics and antiseptics. I'm not in favor of putting antibiotics on a wound. I would prefer to use them systemically if there's a systemic infection. And I think there was some good talks so far in this conference demonstrating the indications for that. Wherever possible, we will try to manage things topically. Unfortunately, at this point, the trials are generally really very small. They're heterogeneous and of short duration, and they're not free of biases yet. But as you know, in the wound care space, there are relatively few high-quality trials in a lot of areas, and I'm hoping in the time to come, we'll see some good quality trials looking at specifically honey in these difficult wounds. There is an RCT looking at 63 patients with neuropathic DFUs where the healing time was considerably shorter in those patients. And so that's by Camaratos, who demonstrated a clear difference, that it was statistically significant. And so makes one consider, if you give honey a chance, that may well be the agent that you go to. A lot of questions have been asked about honey, and I'll try to cover some of them as I go through looking at the different types and my own experience. Some of the questions are, how often should the dressings be changed? Because obviously we're trying to change dressings less frequently if we can to reduce the labor costs and the comfort of patients. Which type should be used? There is a spectrum that should be used, and again, I would suggest that we choose the type of dressing before the antiseptic, as I would say the same with silver. Should the skin be protected, and can it be used in diabetics given its sugar content? That's sometimes come up. So as mentioned, I think the type of dressing, like with any dressing, it should depend a little bit on the moisture balance. I use the time, the algorithm still more often than not because it's simple, and obviously the M stands for moisture. Too little or too much is a bad thing. And so like with anything, I think with honey dressings, the exudate is very important, and the drainage across onto the peri-wound area needs to be managed and prevented wherever possible. So the type of dressing chosen should depend on the exudate and can be varied as the course goes on. The same applies to the next question. The skin should always be protected if possible, particularly in these high-risk patients like DFUs, and it can be used in diabetics. So this would be one algorithm, and I'll touch on it as I describe some of the dressing choices. But we need to carefully evaluate the wound before we choose the type of dressing. And as you can see there, the level of exudate really dictates which type of wound care product we select. So the higher exudate, you would choose a different product to the drier wounds. In the context of debridement, we would prefer a little bit more autolytic debridement to take place to compensate or for the patient's ability to withstand surgery, or to actually augment our surgical debridement. They would also depend on how clean the wound is and whether there's a lot of slough and whether it's infected or not. And then I think very important, of course, to choose a secondary dressing that is going to absorb the exudate and some of the honey that leaks over the wound. So the wound paste, I think, is pretty much 100% honey. It can be put on any wound, and I find it useful to put into tunneled wounds under mining, because you don't obviously need to get it out, and so like a towel, for example. So also very useful in radiation contexts, in stomatitis. It's best for lighter exudates, and also has an applicator that you can apply. And as always, you would need to cover with an absorbent secondary layer. But you can use that agent in addition to all these others. So you can vary the amount of honey that's available by adding the medicinal honey. The Apinator is an extremely interesting product. It's honey impregnated in a calcium alginate. It's quite a firm product. You can cut it and apply it to the wound, and you notice how it gets softer and conforms to the wound. And it's better for moderate exudate and will require a secondary dressing. It does leak over the edge if you don't do this well. Is very good for autolytic debridement, and would often be my first line product in rather than some of the others. It can also come as a rope if you're a tunneled wound. Find it very effective in packing wounds or tunnel wounds. The Hydrogel Sheet is 45% available honey that's in a super absorbent polymer technology. It is cooling, it's got a soothing effect, and it can be available also with an adhesive around the edge or without, and has various sizes, and again is for lighter exudate. So it contributes moisture to the wound. The Hydrogel Colloid Sheet, again, in various configurations, has a decent amount of honey available, also uses that absorbent technology, and again, helpful in managing some exudate. I'm sure we're all familiar with Talgras like Daptic and Gelinet, Bactigras. This one is a finer mesh. It's very stiff initially. It conforms better once it's warmed against the body. There's several layers applied. It's unfolded, and there's more an interface type dressing you could use under negative pressure, for example. I must say I don't use a lot of interface under negative pressure. I prefer the active modality of the granufoam against the wound, but there are occasions where you would want and I would favor something like this over a white foam, which is, as we know, an incredibly passive dressing. In terms of the barrier creams and derma creams that are available, MediHoney has gone the next step that some other dressing modalities haven't gone, recognizing that we need to be managing maceration. And I found this in their various creams incredibly useful in the context where you're not sure whether this is actually a cellulitis. It's in the context of say a pressure sore where the wound is persistently macerated, and I'll talk about a case or two of those as we go along. It's really effective to reduce shear and should be changed 3 or 4 times a day when dressings are done or when there's soilage. Also very effective for radiation contexts. So relatively straightforward sort of algorithm that's used, but the more and more we use it, the better we find its efficacy. This is a patchy chemical burn, some features of localized infection, and a full thickness chemical burn around on this lady's foot. It healed within 3 weeks with MediHoney and Apinate. Patient was very happy with it. It didn't cause much irritation around the edges, rapidly healed the wound without surgical intervention and without even any debridement because of its autolytic effect. I'm increasingly considering honey in these kind of contexts where we would traditionally use another antiseptic. I think having a variety of different antiseptics is valuable. I mentioned acetic acid earlier, but also a bleach or a Dakin solution. And I use a number of different antiseptics in the operating room. To prep, I would use povidone iodine. I think there's value in considering putting a honey, once you've done a debridement, if you're not able to put on a vac, you might consider it for a day or two before you take the patient back after the acute debridement. Increasingly thinking of honey, and I'm showing you some of the more gruesome pictures, but where we've considered various antiseptics and their value. And in this case, this poor gentleman had debilitating end-stage hidradenitis suppurativa. And those of you who manage this condition, you will know how debilitating it is. And in this case, unfortunately, did not receive the management that we would advocate, which is, of course, surgical in advanced stage. And unfortunately, this hidradenitis effectively destroyed his pelvis to the point where when he came into us, he actually required emergency surgery because of exsanguinating bleeding. It was critically ill, and ultimately, unfortunately, required palliation. But we managed to get a part of the wound clean enough to consider closing there. But as you can see, it's sort of cavitating into the pelvis. And from a palliation point of view, we would find honey very useful in that area that I'm pointing to, because it's comfortable, it's cooling, it manages the odor that inevitably is present. And fortunately, this patient ultimately died, but there was some comfort offered to him by that process. Some of the most difficult wounds that I sometimes help with managing are venous stasis ulcers. They're long-term problem. They're very debilitating, and this is one effective dressing choice for the reasons I've spoken about. Trying to convert a chronic wound into an acute one using topical means. There are very few active dressings available. Many of them are sort of bystanders, and this is one of the more active ones because of the biomechanisms that I've mentioned. This lady actually came to me from my colleague, Dr. Casey, who is a passionate wound care practitioner and vascular surgeon, and have a lot of admiration for him because there are very few vascular surgeons who have the passion about wound care that he has. And this patient actually requested an amputation, even though she had good blood supply into her foot. She'd been living with this for 15 years, being managed in the community, and with some careful management of wound care and some surgical debridement, converting again an acute to a chronic wound, we're ultimately able to put on cadaver skin and then go for autografting to good effect. And she was delighted with the results, and we were able to salvage her leg. Some practical tips and tricks. I think, like with any dressing, if it's adhered, soak it first and it'll come off. It does have a low pH. It may actually sting a bit on application, so warn the patient. I haven't really found this to be a problem. Some of the silvers do this as well. It does have a high osmotic potential with its sugar content, and may result in a lot of exudate initially, so warn your patient of that. Some of them sort of have it on overnight and find that their bedclothes are covered with some honey. So the appropriate secondary dressing is important. And then obviously protect the peri-wound area with a barrier if required. This patient is another peripheral arterial disease patient at a bypass. Unfortunately, both operative sites, the midfoot amputation and the groin site, dehisced, got infected, and there was concern and consideration of amputations higher. We felt we could give this a shot where there was no surgical intervention here. She wasn't very fit for surgery and actually preferred not to go that route. And we were able to, with a combination of negative pressure wound therapy, and then as we demonstrated granulation, we moved over to MediHoney to facilitate ultimate healing by removal of the necrotic slough that you see there in the third picture, and ultimately get wound healing that way. And it takes some time, but we were very happy with the result, and obviously so was the patient. Unfortunately, there are a number of patients who are obese. They have challenging wound healing issues, diabetes, and there are times where a combination of strategies is important, including an antiseptic agent, something that debrides, and sort of the times where we can't necessarily do an aggressive debridement or deep debridement for fear of exposing underlying structures. And in this case, the secondary, the surgical management plus the antiseptic dressing choice, in this case an Aponate with the MediHoney, and then we were able to get the wound clean enough to do a muscle flap, a sartorius sort of switch, and then ultimately graft the wound, get it into a suitable state for closure. This is a patient I recently managed, and her course was unfortunately affected by the shutdown and elective surgery. She had a very severe burn, was autografted during her course, facial burn and neck burn, and as they unfortunately do often contract, we released that and we put on Integra, which is a sort of market-leading skin substitute. And unfortunately, just impossible. We were busy with burns. We couldn't get her in, and there was limited elective operating time available. So the time came for us to do the second stage, which is an autograft, but we just couldn't get it done. And so in the interim, we managed her with MediHoney products, with 100% MediHoney, and then the Aponate over the top, and then a good secondary absorbent layer for the moderate exudate. Got it relatively clean. Unfortunately, this last week we were able to bring her in to get her autografted. So it allowed us a time to manage the wound and get her into a place where we could get it definitively closed. Here another severe surgical site infection, where a combination of debridement, a topical antimicrobial was required. And in fact, you can see there the skin graft ultimately done after allografting or cadaver skin was used. And then there is an area of relatively poor wound healing in the center of the wound, as you can see, where the graft is a bit paler. We then started to use MediHoney to clean that up, and to good effect. And I'm pleased to say he's healed. This is a gentleman who'd had a previous amputation on the other side, and there was a lot of concern that he may end up with a bilateral amputation. In fact, he sent me pictures this morning to show that things are healing up really well, and he's very happy with the product. Same is true of this patient who had a cardiac bypass, was discharged from hospital with this terrible wound, with necrotic slough and fat in the wound, and we were able to manage it with MediHoney while we were waiting to bring her in and to get her skin grafting done. So pressure sore is an area, unfortunately, fairly neglected area, particularly those that require surgery, which are the stage 3 and 4s, or should be at least considered for surgery if appropriate candidates. And I mentioned earlier about the moisture-associated skin damage, which you see there. This is a gentleman who's had flap coverage for a pressure sore, but he had this redness. Sorry, I'm moving forward too quickly. We've had some. We had this redness persistently well before the surgery and well after. Actually caused a lot of more trouble in the surgery itself. And we found that the barrier, the honey products, the barrier cream was very effective in managing this moisture-associated skin damage. So there are times, as you know, with pressure sores that we can't necessarily get the patient rapidly into the operating room. Another option needs to be implemented initially. Maybe they're not medically well and need to be optimized for surgery or from an anesthetic perspective. There are a number of agents that we can use. Sometimes we can't get a good seal with our negative pressure, which would be my first line often, to try and augment debridement with the newer foams that are available. But sometimes there are patients and VAC is simply not effective or cannot be applied because of difficult areas in the moisture and how near it is to the perianal region, for example. But this agent is very effective, both just to keep it clean, to debride, and we also use it increasingly in terms of incision skincare because of the adhesive product that we have now available, in addition to in terms of the colloids and the other honeys available. As mentioned before, also there are a number of cases who just simply aren't candidates for surgery or choose not to have surgery because it's not in keeping with their goals of care. And I find, particularly in that context, because of the deodorizing effect and the ease of use and the antiseptic abilities of honey, that it's a good option for them. Here's another pressure sore, getting it ready for a tensor fasciolata flap. So it's one of the adjuncts we use in preparing the wound bed, in addition to debridement itself on the operating table. And many of these are done as emergency cases, even though they're truly elective, and because of shortages of operating time, that we often need to consider an effective antiseptic prior to surgery to limit the number of operations that we subject them to. Here's a case where my choices would be either negative pressure or honey, depending on the context and the ease of keeping it in place and debriding, closing that to good effect. Same here with this young man who prolonged ICU stay with number of surgeries, ultimately requiring flap coverage and to good effect. And he's now a year to 18 months down the line and sustained closure. And thanks to the antiseptics we use, MediHoney, negative pressure wound therapy, and surgery. This middle-aged gentleman with a adductor contracture, multiple pressure sores, ultimately getting a flap for coverage. But again, just to augment our debridement, to facilitate further autolytic debridement in a difficult area, and this would be one of them, and ultimately getting good cover and getting them out of hospital with durable skin closure with flaps. This is one of the more impressive cases that I worked with one of our nurses to get closed. He had a number of other pressure sores. This one was arguably the most challenging because, of course, as you see, there's a fistula from the bladder, and actually relatively young gentleman, high functioning, but a devastating wound that's long standing. And actually this wound, other than a Versajet, light debridement with backing it up with MediHoney, actually able to get a lot of that closed without too much intervention while we were trying to address the other pressure sores. I see a lot of trouble with pressure care here, and a lot of multidisciplinary input in terms of getting this closed. See a lot of these very severe pressure sores where there's obviously an argument for managing them non-operatively, just because of the relatively few options given the extent and the condition of the patient. This unfortunate gentleman, actually relatively young, came in with septic shock, needed to be debrided because of that right trochanteric wound, and then brought back 2 or 3 times in the first week, where you may not justify putting on a negative pressure, for example, in the context of partially unmanaged infection, where you can't necessarily get an installation option going. A good agent would be honey here to complement your surgery, to assist with debridement, and to be sure that you're managing the wound topically, and ultimately you're able to get that closed and get them going. And a lot of, I think, many will agree, getting a bad pressure sores closed are some of the things we can do as medical practitioners in the wound care space that will offer a lot of comfort to patients and take away a lot of their hardship. This is one where we just simply could not rationally offer him surgery because of his general condition. The one more because of as much because of the wounds and the relatively few options available and his general condition, and the other because of her palliative condition, where it really wasn't something we were going to offer from a surgical perspective. So I just wanted to reinforce that honey should be considered a first-line option. It's been healing wounds for thousands of years. There are a number of beneficial effects described. There are increasing reports of beneficial effects from an in vitro and an in vivo perspective that are being applied clinically. There's a growing body of evidence for its efficacy. MediHoney is the market leader in this area, and described how Manuka is the preferred choice. It's got a number of unique properties that are a multi-pronged approach, which we need for the MRSA and Pseudomonas associated biofilm infections. And there are a large number and variety of products available depending on the indication and the level of exudate, especially being one of them. And so I'd encourage you all to consider honey as a first-line option. I know a lot of people are using it increasingly because of its user-friendly range of products, but increasingly it's sort of making its way into the top of the armamentarium rather than as a second-line option as it was previously regarded, particularly with the problem with antibacterial or antibiotic resistance that we have. Thanks very much. I'm eager to take any questions and any comments. I'm sure there are people out there with a lot more experience than I do with a range of different wounds. So thanks very much. Thanks, Leslie.
Thanks, Dr. Rogers. That was excellent. We do have a number of questions. I'm going to try to combine some of the ones that are similar. So number one, I've got a question about Pseudomonas. So do you use MediHoney for Pseudomonas? And then if you do, in terms of your treatment algorithm, where does it sit with other advanced wound care products? Are you reaching for other advanced wound products first before you try MediHoney, or is it higher up in your algorithm?
Thanks, Leslie. It's increasingly higher up in the algorithm. Can you hear me?
Yes.
Yeah. As I mentioned, it's increasingly moving up. I think traditionally in our context in the burn care space, we were fairly conservative with our approach, being an acute wound rather than often a chronic wound, that many of the wounds that we weren't operating on would heal spontaneously, and arguably an antiseptic would, virtually all of them are cytotoxic. We would vary the antiseptic slightly and use simpler ones. Silvers and some of the bleaches, the Dakins, Vash, and other options. But I think MediHoney is increasingly, because of the product range and how user-friendly it is, and once we've come to understand it, I think it's moved right up to the top of the algorithm, particularly in chronic wounds. And because of, I think we need to consider it again as a first-line agent rather than something we would rely on only sort of once all the others have failed. I think I think that's the mindset shift that we need to change to.
Great, thank you. We've got a couple of questions on cleaning the wound bed with MediHoney. So the challenges that we've encountered from this doctor said that with medical honey is that sometimes it's difficult to properly clean or debride the wounds, as it's obviously very sticky. So do you have any advice or feedback on how to clean that wound bed if you're using MediHoney?
You mean to clean the product off?
Yes.
I mean, I think just soaking it very well with, put a moist gauze over the top for a while helps. I don't know that you necessarily, because the body will moisten and actually come off with time. I don't think necessarily there's a reason to scrape it off and cause pain in the anesthetized patient. There are nuances, like with any dressing, to how it's used, and some of the all dressings have their downside. I think one needs to understand how it works and how it behaves. As I mentioned, one needs to know particularly how to manage the drainage and the exudate very effectively, and with MediHoney. I think that the confidence that it gives one in terms of the variety of antimicrobial effects and anti-inflammatory effects outweigh some of the negative issues about, as I mentioned, the drainage around the wound. I think We just need to learn how to manage it differently. I think the same is true with some of the other agents like Aquacel AG, which can get very stiff if not moist enough. There are different other agents, other dressings that need to be managed correctly. They need to be understood before we really use them effectively. And I think honey is just like that. I think its beneficial effects outweigh some of the initial learning curve in terms of how to treat it. And we learn from our patients. I must say, I have, even this last week, she said how she dressed the wound, or advised the nurse even to dress the wound in a way that made it more effective in terms of managing that exudate and getting it off. We often hear in the community patients being told they can't shower. This is one of the more ridiculous things. I mean, we want the wound to be cleaned. So we always, you always get the patients to get into the shower if they can, wash it off, soap and water, and allow that to do some of the work in terms of getting the dressing off. So, and then the dressing can be applied. If it's being done in the community, have the shower first and then have the dressing applied if it's not being done by the patient.
Great, thank you. Have you come across any contraindications or patients that you wouldn't use MediHoney in?
Not really. I mean, it is described that some patients find it can sting. I haven't actually seen that. I've seen that with other dressing modalities. For example, Acticoat Silver, some patients get a stinging sensation on application, actually can't bear it. I haven't found that to be the problem. The more sort of the learning curve for me has always been, and I actually found it's often soothing. The learning curve's been more about some people comment on the drainage, and I think that's just the way we dress it needs to be done more effectively. Right. I don't see there being any contraindications at this stage. In theory, I guess some people may have a reaction to it, but I haven't found the adhesive to be particularly irritating in those products like the Hydrogel Sheets that have the adhesive. I haven't found that to be a problem. But some people inherently don't like the adhesive and it gets inflamed, but not the honey per se as yet. Right.
Excellent. Thank you. We have a question about radiation stomatitis. So have you had any experience using MediHoney for that? Have you thought about, or have you tried using it as a mouth rinse, for example?
So this is not an area I'm particularly involved in, although I've had a discussion recently and discussed with one of our expert nurses who's partly involved in that space. And she loves the medicinal honey use in that area and for stomatitis and radiation-associated damage. And so I have heard very good things. I know some people, there is a study that I read using plain table honey for swishing in the mouth, but again, the medicinal use on wounds is probably better to use the better studied medicinal honey for those indications. So I've heard very good things about its use in that context in the radiation sphere. So I would encourage that.
Okay. We've got a follow-up question in radiation as well. So our questions in the audience, this person's had some good success anecdotally using MediHoney barrier cream in radiation. Do you share that? Have you had any experience or success with the barrier cream in radiation?
Yeah, again, the nurse I work with is just a phenomenal colleague. She described using it even for a relative of hers to good effect, and is advocating it as a first-line agent for that indication. She's a tremendous wealth of experience in that area, and so I defer to her for that, and that's what she says is her first line. So I think that speaks volumes.
Excellent. What do you recommend for use of graft donor site from the left lower aspect of the mandible area?
Sorry, a donor site on the mandible.
Yeah.
I'm assuming the recipient site. This is for a patient with a free flap with breakdown around following a reconstruction after head and neck cancer, I would assume. That would be more the recipient side of a flap. The graft may be the free fibula or the scapula or some other area with bone potentially. In my training, there was already I have a fair amount of experience with doing these cases and assisting with these cases, and these are patients who've had radiotherapy, chemotherapy. They're often malnourished, often smokers, alcoholics who have many of these cases, and I think oftentimes not good candidates for further surgery. There's good evidence coming through that medicinal honey, in addition to one of the other products, probably the apinate, with an appropriate overlying dressing, absorbent dressing, is very effective at cleaning up these wounds, debriding them. And I've heard good things. I don't know that it's necessarily widely used in that space, but I'm hoping that it is increasingly used, both in the academic setting and in the community.
Excellent, thank you. Do you find that the MediHoney gel will stay in the wound, or do you find that it has a tendency to leak out as it warms up with contact with the human body?
Yeah, it has that property of flowing and then gelling. So it does depend a little bit on how much you put in. It depends on the exudate. So yes, it does have the tendency to flow out. So again, the dressing choice, overlying dressing choice is as important. But yes, it does have that tendency. As I mentioned, one of our patients had a dressing on her neck, and she found that the bedclothes were covered, and she said, she doesn't mind because it's got a soothing effect, and she actually quite liked the odor. So again, you've got to balance that. I think there is a learning curve in terms of the overlying dressing choice, and I think in many of the contexts, ExtraZorb is described as the overlying dressing. Some people use abdominal pads or gauze or Curlix, but you need to have an emphasis on that overlying dressing to have the best effect. But again, the amount, it's a sort of a judgment call as to the amount that you fill up the wound with the gel before the other agents. So there isn't a desiccating effect that it has. It does draw the fluid out, and so can certainly flow out over the wound or over the wound edge.
Okay, excellent, thank you. You did touch lightly on negative pressure therapy and MediHoney. Do you mind commenting again about your experience using the two together? And if you are to use them together, how do you use them together?
Yeah, it's more conceptual thing for me than necessarily a lot of experience, because my preference generally is to apply the foam directly to the wound wherever I can, because that's going to have the most direct effect. Now, as I mentioned, I don't use the white foam, which is a sort of passive agent on more important structures. I prefer to use an interface. And so I have had a few cases where I've actually applied just to a specific area to protect the underlying, because dressing is to use the towel option. And I think that's a good option that I've used just as an interface in that area where I wasn't necessarily looking for granulation. I was looking to protect the wound. Perhaps there was some necrotic slough or something like that in that area, or a structure that I'm trying to protect. I would look to use an interface of some form. But in general, I prefer to apply the foam directly to the wound. So it's more complementary. There are times, and I'm increasingly using it, but I think it depends what you're trying to achieve from the wound. So the more I sort of experiment, the more I would do it. I don't see any contraindication to doing that, particularly the towel dressing. I think that's a very good option under negative pressure.
Perfect. So you put the towel underneath the foam.
Right. Yeah.
Perfect. Thank you. Can you comment on which MediHoney product you would use for a recalcitrant 18-month venous leg ulcer with a red-yellow mixed base? Revascularization was done 8 months ago.
8 months she had this wound. So my general approach is to look at the patient and sort of, if the vascular surgeon is happy with inflow, that it's principally an outflow problem. If he's happy that compression is optimized, elevation and offloading is optimized, then we would ask, is this patient a candidate for debridement or not? And formally in the operating room, is it a large wound? Because I find often just converting the wound from acute to chronic, chronic to acute, is often helpful just in and of itself, and then supplemented by an agent like probably the aponate initially, most often, which you can cut exactly to size, and it's a little more versatile. You can put some more honey underneath it if required. If the patient's not a candidate for surgery, or there's going to be a delay, then absolutely would go for this option first. And generally, I would say the aponate is the option I would use with the medicinal honey to augment. If there is a depending on the amount of, if it's drier, I would add more of the medicinal honey or the gel underneath the aponate. If it's moister, I would sort of not require that as much. So that would generally be my approach to these wounds.
Excellent, thank you.
Worth trying, but it's going to take a bit of time. But it's one of the more, as I mentioned, more effective debriding options that we have. One of the more active options, and the old method that we all sort of as the standard, not necessarily standard care, I don't think we do it often anymore, but the wet to dry approach is extremely painful for these patients, and I find this more active autolytic debridement is more effective.
Great, thank you. To follow that with a chronic wound, how long can you use MediHoney on a chronic wound? Is there a certain time period, or do you kind of call it quits at some stage and move on to a different therapy if you're not seeing results?
So as I mentioned, my main practice is probably mainly acute. I do get referred some patients with long-standing wounds, and so by the time they get to me, often we're looking at surgical options. So I would say 50-50 go the surgical route, and some. So if there is always that delay to necessarily get them into surgical space. So often it's preparing the wound bed for that. But I would say it's right at the top of the algorithm now with the benefits that I've described. I think it's worth trying. The duration, in principle, I wouldn't use one antiseptic for a very long time, but MediHoney is kind of changing my thought process there. I think if you're not getting the results that you want, then you've got to look at other options. So how long would I do that for? Probably 3 to 4 weeks before considering an alternative agent in the chronic wound space. In the acute wound, it might be 2 weeks.
Okay, wonderful. The next question is that, do you have any experience using MediHoney for Category 3 skin tears?
I don't really see a lot of skin tears as much. As mentioned, I'm mainly, as you've seen on my pictures, it's mainly extensive wounds and the occasional chronic wound that's recalcitrant, but I know it's well described and effective, assuming it's used in, as I mentioned, in terms of using it appropriately and recognizing its pros and cons. I think it's an effective approach because it manages the potential infection, it reduces inflammation, and it's comfortable, and so forth. So I think it's a good option for that category of wound as well.
Excellent. We just have a minute left, so I'm going to wrap this up. There are a couple of unanswered questions, so I would ask if the delegates don't mind popping over to our booth. We've got our clinical team there and our sales team there, and more than happy to answer your questions. So we will keep track of these and make sure that everything gets answered. Dr. Rogers, I want to say a big thank you to you for this excellent presentation, really informative, lots of great history and understanding of MediHoney, so we do greatly appreciate your time. And a big thanks to Wounds Canada as well for facilitating and having us today. There's going to be a survey that will be ready immediately. So please, we ask that you fill out your survey, let us know what you think of the content, and help us get better. And again, big thanks, Dr. Rogers, for your time and for this really great presentation. So thank you very much.